I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. I'm very excited. I'm very, very excited to welcome Dr. Lara Hochman. She's one of my heroes, and I don't want to steal your thunder. So, Dr. Hochman, if you would introduce yourself and kind of tell us a little bit about yourself, that would be great.
Awesome. Thank you. Well, thank you for having me here. Gosh, fun to hear, when someone's here. I like that. So I'm Lara Hochman. I'm a family medicine physician. I still practice medicine, and I do a lot of work in physician advocacy. I really believe that we have the ability to change our surroundings. We have the ability to create the lives we want. So a lot of the work that I do is in physician employment, so helping to match physicians with physician-owned private practices. And a lot of the work that I do is in helping coach physicians through even just figuring out what they want. Whether people call me knowing what they want or not, I really enjoy doing that. And I've had a really fun time doing this, and I'm excited to see what we're going to talk about today.
Sure. Well, I'm really looking forward to it also. Lara and I were talking a little bit earlier about, a lot of the guests that we have on the show, and the recurring theme is that every single one of the guests is somebody that either has thrown out the box or has been thinking outside the box. And that's one of the reasons I admire you so much. When I first ran across you, I ran across you as the physician matchmaker, I think is how a lot of people have come to know you. But you weren't always the physician matchmaker. Can you tell us about your journey? Where were you, and what pushed you to go in this direction?
So I started out in private practice. I don't think I've ever been an in-the-box thinker, so I think we just need to put that out there. When I graduated residency, I had just had my first kid, and I did not want a regular job, and also my husband was completing his training, so I worked locums, and it was locums just in the city I was in. I didn't know anyone doing it. I was just like, well, I don't want to work full-time. I want to spend my time with my kid. So even starting at the beginning, that wasn't a thing that anyone was doing, that I was just like, I'm going to make this work. I worked the days I wanted. It was awesome. Moved to private practice when we moved. So he finished training, moved to private practice, just regular old family medicine, did the whole burnout thing, left medicine entirely. Because I was like, what am I doing? Because as you mentioned, there's a lot wrong with medicine. So I left medicine, thought I was never going back, and got a message from a recruiter about what sounded like an awesome job. Figured, hey, what have I got to lose? Let me give it a try. A regular primary care job without insurance. That was 7 or 8 years ago, and I'm still there, and I love it. And I think that's when things, in my time off, when I was not a doctor for that very long 3 months, best 3 months ever, I had the feeling that I wanted to do something. I wanted to be part of the solution, not even anything big, just, things are broken. How can we change them? And I almost just fell into it because, I saw what it was and I saw what it could be. And I wanted to be part of bridging that gap where I can help physicians find those jobs that are really awesome, because we don't need to be miserable in our jobs. We have one life. Every moment is just that moment in time. We should enjoy it. So that's kind of how I fell into it. It was just, I need to do something. Oh, here's a thing. Let me give this a try. And here I am doing it. So
that's awesome. Now, you've got a pretty substantial following. There are a lot of physicians that I think look to you for all kinds of wisdom and guidance. I mean, how did you cultivate, such an audience?
Oh, goodness. I would say semi-intentionally. I didn't, I think I just put out there what I think and what I believe, and it resonates. A lot of what I speak about, LinkedIn tends to be the platform that I use the most. I've tried them all, but LinkedIn is where I do a lot of the work in posting, and I think it just resonates. There's a lot of issues that we have, and I just post my thoughts and my perspectives, and here's what we can do to change, and here's how to think about things, and here we are today.
That's awesome.
I guess.
That's so exciting. Now, you had mentioned burnout, and I know that that's a really big concern for a lot of the people in our audience. I talk to medical students and residents these days, and unlike when I was in training, it seems like almost every single one of them is thinking, oh, what am I going to do 10 years after residency? And of course, my thought was, I'm going to be a surgeon, but that's not what they're asking. And they're very much concerned about burnout. Tell us about your experience with burnout. What were the things that were wrong or that were broken that led to that?
It was a mix. So part of it is the system that, the charting after hours, there was a lot of pressure that I put on myself to be perfect. I would say there's a lot of internal stuff. I think with, since I'm aging myself here, but when I graduated training from residency, the internet wasn't as big of a thing as it is now. And over time, people are very skeptical. People are coming to us doubting what we're doing, and we're humans, and we're not expected to be humans. So other than the usual thing of paperwork and lack of autonomy, that was a big one for me because I put a lot of pressure on myself to be perfect, and I wanted to figure things out. And a part of that was great. I mean, I had people flying in from all over the country to see me because they had diagnoses that no one else could figure out. So there was the perfectionism thing was great for the patients.
Sure.
However, it was a lot. And, being on call and getting calls during my kids' birthday parties or while I'm out with friends trying to relax, that being on all the time was just not, it's just not great. The charting, all of that stuff. Burnout sucks. I mean, I found that I wasn't present with my kids when I was putting them to bed because my brain was somewhere else. If I'm upset, if I was unhappy at work, I was going to be unhappy at home because I couldn't separate. If I'm unhappy, I'm unhappy, So that was burnout for me. And when I left, it was great. And I had this amazing reset. But it definitely was something that I was intentional about and decided if I ever feel that way again, hopefully I would notice it and then do something about it sooner next time.
Sure. So what's different now? What did you, it sounds like, okay, you learned all of these things, to hear all the things that are broken. What lessons did you learn from that? And then how did that lead into what you're doing these days?
A big one was boundary setting. When I had my second kid in private practice, I learned to not be such a perfectionist, and my note writing shortened. So I was not charting after hours all the time. But that was in the private practice that I was in. Where I am now, we don't take insurance. So I get to chart what's relevant, which seems so silly that that's a thing, but I am not counting my bullet points. I'm not making sure I have enough for a 99214 or is this a 99213, all that stuff. Surprisingly, that alone changed, that gave me back an hour or more of my day because I get to just chart what's relevant. I have plenty of time with patients. I don't do a lot of the admin. So I love that. And I know what my boundaries are. I know what my values are, and I very strongly stick to them. So for me, I know I need to be with my kids. I know that when I leave, I'm done, and I do everything. To make that happen, I make sure that I finish my notes as soon as I'm done with the patient. My time management at work is great, which is a lot easier when you don't have as much admin work. I have that admin support. I take lunch breaks. I go home at the end of the day. It's very much what happened inside of me as well as what I was willing to negotiate on, compromise on. I know what my non-negotiables are. And I live that every day. Life's short. Why be in a job that I hate?
That's awesome. Now, you mentioned that previously you were counting bullet points and then doing other crazy things like that so many of us have done in the past. And now you just chart what's important. So for the members of our audience that don't know the difference, what are the things that you notice that you don't have to do anymore because you're not having to, to deal with coding and billing.
What do I not do anymore?
Yeah, like in terms of charting. We'll start with charting.
Gosh, yes. Okay. Review of systems wise. So the counting of the bullet points, like you count how many questions you asked during the exam. You count how many, we call it the review of systems in medicine. How many, did you have sore throat? Do you have chest pain? Do you have trouble breathing? Which sometimes it's not even relevant to what the person's coming in for, but to be able to get paid for the visit that you're doing, we need to be asking these questions. So it takes more time to type it out or dictate or however you do it. And then you're also counting it. The physical exam, I'll say things now. My physical exam is something like, no acute distress, vital signs, heart, lungs, mental status, and if someone's sick, I'll say that they weren't sweating. Done. I know it's relevant. I put it in my note. For insurance purposes, I would put no acute distress. I don't even remember anymore. It's so silly. But then I would say that their eyes are not red or yellow when they're here for depression. Well, sure. I guess that could be relevant, but
or an ingrown toenail.
Ingrown toenail. There you go. Or all these silly things. Like it's not relevant that their hair was messy or that they had moist mucous membranes, that they were well hydrated. All those things that are so silly. And then you have to count up how many bullet points in each body system. And then I would notice, oh goodness, I'm one bullet point short of being able to code this to get paid for enough for the visit to make it worthwhile that I can keep the lights on, essentially. So then you go back and you say, okay, what else can I add? I'm going to add that they had good dentition. They had good teeth. Like, what? Who cares if they had good teeth? So silly. So silly. Same thing with the plan. I mean, it's every part of the note. You want to make sure that you added their surgical history and their medical history, and it's just a complete waste of time, in addition to all the other stuff that insurance companies make us do.
Oh, my goodness. We could talk for hours on that, I'm sure.
Yes, we could.
So let me ask you this. So you mentioned that you don't work with insurance any longer. And I love that. That's so exciting. Obviously, that's the big focus of our podcast. What does your practice look like? Like, how do you keep the lights on if you're not doing anything with insurance?
Okay, so I'm going to preface this by saying that I think all doctors should start their own practice or join a physician-owned practice that is financially viable. I know that for me, I don't actually want to run my own practice, so I don't have my own practice. I work for someone else. This is an employer-based system where in big employers, so large companies, will hire my company to provide full primary care to their employees. It's wonderful. So it's similar to the direct care model where the employer pays a per member per month. So just say this employer has 5,000 employees and they pay, I don't know the numbers. So actually, I'm not even going to make something up and give anyone a false idea. I used to, but I don't anymore. But just say they pay, for ease of numbers, let's say $1 a month, right? $1 per member per month, which, trust me, it's a lot higher than that. So they're paying $5,000 per month for all of their employees to be able to go there. Because of that, so we can, we have 30-minute visits, 1-hour physicals. If I have a patient that I know is going to need more time for all the reasons we all know, I guess for those of us listening who don't all know, that could be someone who maybe is going through a really hard time and I know is going to come in crying and need a shoulder to cry on. I'm going to block the time after that within reason. Or if I have someone who's coming in for a really complicated procedure, I'm not going to do that in 30 minutes. I'm going to block the time afterwards. So I have that autonomy to make the right decision of what's right for my patient, which is so sad that that's even a question. But I have that ability. I have great people I work with. Our company tends to take good care of its people. So because of that, I know if I say, hey, I don't want to do these prior authorizations, especially with all the GLP-1s that are coming out that all require, I even tell my patients, I'm going to prescribe this to you. Your insurance company is going to tell me I'm not allowed to prescribe it. I'm going to write a note back. And I even joke, I'm like, actually, I'm not going to tell them, my office staff is going to tell
Sure.
them. But because we have that great relationship, I feel comfortable saying, hey, can you guys do the prior authorizations? Can you do the things that don't require a medical school degree to do? And they do, and we get along great, and it's a well-oiled machine because of all of that. So
that's awesome. So yes. What you have effectively is a subscription model, right? Like you said, very similar to a direct primary care practice. And so, again, for the benefit of our audience, rather than a fee-for-service model where, the patient or the employer pays for each individual visit and each individual diagnosis and so forth and so on, they effectively have a gym membership with you instead. They come in once that month or they come in 30 times that month. It's still the same subscription price. Is that about right?
Yeah, so it varies a little bit based on which employer it is. So each employer sets their own price. So some employers, we have one that all of their employees are relatively underserved. So they pay nothing. Those employees pay nothing to come see us. So they can do absolutely anything within the clinic. We have more than just primary care there. They tend to come in a lot, which is great because they need it. We've gotten A1Cs down from 13 to 6 because they weren't getting care before. And we take great care of them. And then we have some employers who do charge copay so that their employees don't come in all the time. But it's a really manageable copay. It's significantly lower than it would be out in the real world.
That's awesome. Now, what have you found are some of the advantages of a subscription model like you described versus the fee-for-service model?
At least on the patient side. So I'll speak from the patient side first. I find that the patients will not wait until everything gets tremendously bad to come in. They have an issue, they come in. Sometimes a little bit too much. I had a patient come in once for 30 minutes of a sore throat. So, I was like, well, it's too soon for me to really say, but this is what I think is going to happen. But they do tend to come in sooner. They don't bundle up all their 50 issues into one visit. So I have more time and I have more time, which is great. Because of the subscription model, there isn't that need, business is math. So there isn't that need to have this huge churning out of patients to be able to keep your lights on, to pay your staff, all of that. There isn't that pressure because you know that you're going to get paid enough to pay your staff, to stay open, to do all the things, and to have enough time with patients. So it really, and in addition, if the physicians and the office staff and the front desk staff and everyone that just makes the place run smoothly, if we're all happy, we're going to take better care of the patients. And so patient care is just better. It's just better.
That's awesome. And it sounds like a lot of the work that you're doing is more proactive than you probably were doing in your, in the private practice you were in previously. Does that sound about right?
Yeah. I think wherever I was, I would put a lot of focus on preventive care. But I think the ability to have more time with people definitely allows that more, because if someone comes in for a sore throat or whatever it is, I'm like, hey, while you're here, I can be done with the sore throat in 10 minutes. I'm like, oh, while you're here, check this out. We need to update your medications, or we need to get a flu shot, or whatever it is. There's just that time, and it's just better. It's better.
That's awesome. So, is your company, the practice that you're a part of, I don't imagine it's the only one out there that does the kind of work that you do, that there are probably other companies out there that are also, set up to work with employers like that. How common would you guess that is? Is this something that's, rather unique to the market that you're in, or is there a need for this that's untapped?
There's a big need. And, seeing as this is a direct primary care or direct care practice, I will say I've known small direct care practices to do this with small employers. So the company that I'm at, we take large employers, like large, the names of all the companies we see their employees from. There's a few of those out there. But all of these big companies that, like the one that I work for, they take big employers. The small employers, like the Restaurant Association or maybe the small hotels. It's a way that they can, if they were able to offer this to their employees, maybe they can't afford health insurance, but they can afford to pay for a direct care model. So I see this, if you're listening and you're a medical student or resident, you're thinking, how can I do this? This is absolutely something that's doable for a small practice to do. You just want to go for the smaller employers.
That's awesome. So then when we talk about the employer relationship, one of the things that I would imagine some people are asking now is, well, if I go work for the employer, then what about privacy? I mean, does the employer then have access to all of the patient's medical records? I mean, I'm not sure I want to be in that kind of situation. How would you answer that question?
Yeah, they have absolutely no. It's just like a regular doctor's office. So we have some of the practices we're at, which are on site. We used a different internet provider. We had our own. We don't use the company's internet. We had our own servers. I mean, the whole thing is completely separate. And so we kind of talked to them about that. The off-site ones are a little bit easier for them to understand that it's different. But no, I mean, it's against the law. We could lose our license if we share their personal, private medical information with their employers. So there is a little bit of education that goes on with that because they are afraid, and I don't blame them. I don't want my employer knowing anything about my medical anything. So yeah, I mean, I find the off-site, the ones that are not in the building, definitely have a little bit easier time not having those conversations. But when I was on site, we had those conversations a lot.
That's awesome. Now, one of the things I hear a lot, and I know a lot of people that feel this way, is that given all the changes in medicine that have occurred over the last 20, 30, 40 years, most of it centered around finances and insurance, the majority of physicians today would not encourage their children to go into medicine. But it sounds to me like, given the model that you're in, I would guess that that your colleagues who are in the same practice would have a different take on that.
I think to each his own. I think certainly less so, for sure. I mean, the doctors I know in direct care, in concierge, even in insurance-based practices that they own themselves, tend to be so much happier and are confused why not everyone doesn't do this.
Sure.
A lot of my clients, the practices that are owned, physician-owned practices, they say to me, why doesn't everyone do this? I don't understand it. Why? And they have a hard time finding physicians. And they're like, why are we having a hard time? Why do people don't they know that this autonomy is amazing? It's very interesting. There's this disconnect. And I think a part of that is our training. We're trained to not see the private practices. We're trained in academic centers. There's a different way of thinking about it, but it's really interesting. I mean, definitely lower rates of attrition in that I see, at least anecdotally, in physicians who have that autonomy, for sure.
Sure. Now, let me ask you this. So let's dig a little bit into your role as the physician matchmaker. How do you connect physicians with these independent practices, with these physician-run practices? Like, I mean, is there a bulletin board somewhere that you go to and say, oh yeah, look here, there's a whole bunch of jobs available? I mean, how does that work exactly?
There's different ways. So if I'm working directly with the practice, so I'll work with the practice. They very closely, we talk a lot about what their practice is like, what the right person would fit like there, what the culture of their practice is like. And then it's a matter of going out and finding the physician. That's not easy because there are more jobs than there are doctors. And a lot of doctors are looking for a lot of things, and a lot of doctors don't even know what they're looking for. But ultimately, it comes down to finding the right person that is willing to take that leap of faith into private practice. And a part of that is typically compensations has tended to be lower in private practice because they're not reimbursed the same by the insurance companies. I feel like we keep coming back to the insurance companies here.
Yes.
So there's the one way. The other is if I'm working directly with a physician and they come to me and say, hey, can you help me find a job? Then there's a lot of, first we'll talk about what it is that they're looking for, what their values are, what they're willing to compromise on. How important is salary? That's a big one. That's probably the biggest thing we talk about, because for a lot of people, it's not really negotiable. They say, I need X amount of dollars because I have this many loans. A lot of physicians I've spoken to support their families in other countries. So we talk about money very importantly, because that may actually determine what kind of job they're willing to take. And then I go out and find them. And we do a lot of coaching through interview technique. I'll edit I'll tell them how to edit their resume. So we do a lot of work through the whole process to find that. But really, you have to want to find that in order to do it. You know what I mean?
Sure.
You have to be ready for that.
Absolutely. If you had to guess, what proportion of the connections that you make end up being in direct care practices?
Oh, very low. Very low.
So most of the people that you're connecting are going into physician-owned insurance-based practices.
Mm-hmm. Yeah, I'd like to see it more. The direct care practices that I've had the most exposure to tend to be very low budget. So in part, it's because they're not going to pay for my services, which is okay. But also, I'd like to see direct care practices being able to charge their patients enough that they have that ability to use services that could make their lives a whole lot easier, or not, and take that more, the profit for themselves. But that's a big one. And then another reason for that is that a lot of physicians going to direct care practices don't want to take the salary decrease that would be the starting salary before the salary grows.
Sure.
So a lot of direct care practices and physician-owned insurance-based practices too, they would have to supplement the salary of the incoming physician heavily. There have been practices I've worked with, insurance or direct care, that have actually, the physicians that own the practice said, I'm not going to take a salary for a year while the other physician is building up their practice so that I can pay them, because nobody wants to work for free. So there's definitely some challenges in having doctors join. But oftentimes, if you can get on the money side of things, if you can build up your practice, if you have that bedside manner and you have that charisma that you can build up your practice, oftentimes you'll end up with a higher salary than if you were in an employed model, and a better quality of life. But you have to take that chance of having the lower salary to start.
Sure. So of the doctors that end up in a direct care practice, whether it's a direct primary care or direct specialty care practice, what have you noticed are some of the common traits that those doctors have that kind of push them in that direction, or convince them, okay, that's the way I want to go? Are there particular personality traits or particular goals that they seem to share, other than not dealing with the hassles of insurance?
Well, that's interesting, because none of us really want to deal with those hassles, and we all gripe about it, but who actually does something about it? I think probably it would be courage would be a big one, because it is very scary to start your own practice, and especially something that's still so outside the box. So courage would be a big, big, big one. I'll kind of not answer your question a little bit. And I think something interesting I've seen as far as traits of all the different direct care practices, those physicians that I've seen, is that wherever you go, there you are. So I've worked with, one direct care physician who was so overwhelmed with I think he had 350 patients or 450 patients, but it's because he has that workaholic hustle personality, versus, physicians who are in very extremely busy insurance-based practices who have, all the work coming at them, and they're totally fine. So I think as far as traits go, don't forget that wherever you go, there you are. I'm a workaholic, and I have to actively make a note each day of, oh gosh, I forgot to make sure I had time to eat lunch, or oh gosh, it's easier in clinic than it is when I work from home. But wherever I go, there I am. So if I'm a workaholic, I'm going to be a workaholic. So yeah, the traits that I see, I think everyone's very different, but probably courage would be the biggest one, because that's really scary to start your own thing. And it's really scary to tell your patients, I'm not going to take insurance, but pay for me anyway. And I'm that awesome that you should pay for me without your insurance.
But ultimately that, in the end, each and every one of us as a physician is awesome in our own way, right? I mean, it sounds like that's the lesson that you had to learn, was that you have value. And so do you find that tends to be a challenge for a lot of physicians who come to you looking for help, that they don't know their own value, and as a result, it's hard for them to figure out what they want because of that?
Yeah, I think part of it is it's the imposter syndrome that we all have. I think it's a matter of letting go what we thought we wanted, grieving what we thought we were going to be in. Yeah, I definitely see that for sure.
And then how do you help these physicians who haven't had a good sense of their own value? How do you help them to understand and realize that?
Oh gosh, well, I'm not a therapist.
Well, from a professional standpoint, like in terms of the coaching and things like that. Because obviously in an interview setting, each of us, I mean, we've all gone through these interviews, right? Whether it's residency, fellowship, whatever. And ultimately they're asking, well, why should we take you? What makes you so good that we should take you instead of Joe Blow? And ultimately that's a value judgment, right?
When I do when I do a lot of coaching through what to say in an interview, and I never tell people you need to say that you like XYZ when you don't. It's all about just communicating who you are and what you value and what you're good at. I think what I say, probably just as far as like, I'm just curious and I really want to know more about them. Probably that alone is in itself. But yeah, communicating to them like, hey, don't be humble. Tell me what makes you awesome. That's probably, I think that's it. Because like, well, I guess some people would say, I'm like, no, tell me, instead of saying, well, I think people like me. I'm like, no, I am well liked. Let me hear it. If you're well liked, own it. That's awesome. Good for you. So I think, it's hard to say, well, I'm a nice person, I'm kind. It feels so awkward to talk about yourself that way. But we are awesome people. We're doctors. So
exactly.
Own it. Goodness gracious.
Exactly. So as we kind of wind up here, I want to ask you one really, really big question. Probably the one question that every single one of our listeners wants to hear your take on. Given all your experience, given the ups and downs of your career to this point, and the joys, the triumphs, the failures, what would be the advice that you would have for our listeners, to the medical student or the resident or the fellow who's trying to figure out, how do I avoid burnout? Is this direct care stuff for me or not? What would be the advice that you would give them? What do you wish you had known when you were in their shoes?
What I really wish I would have known back then was how to create the balance, how to listen to myself. I don't think I listened to, and I don't mean listen to myself like singing in the shower or anything. I mean, I don't think I was really attuned to my feelings. I think that I stayed in jobs that were pretty miserable to begin with, and I always made excuses for it. I was like, well, it'll get better. I think it'll just be 2 years and then I'll be more comfortable. I think when I'm, when I've done this for longer, I'll XYZ. Or I think, I love the prestige that comes with this job, or I love the whatever. Like, why is that important? If I'm miserable, I'm miserable. So I really wish I had listened to that and just cut my losses and be done with it. It definitely put me in a good place for, being an awesome doctor. But I kind of wish that I'd listened to myself earlier. So I think that would be my advice, is really listen to yourself, figure it out. I think the younger generation, I mean, I'm not that old, but I think the younger generation is so much more attuned to their feelings and journaling and all these cool things that were just so taboo when we were younger. It was just, you do what you're told, end of story. So be attuned to yourself. And I think a big one is communicate and truly, truly listen. What I see nowadays in medicine, in employment, in everything is it's very much an us versus them mentality. And I think if you really get to know someone, and if you really get to know the reasons behind why something is done, it gives you a different perspective. And you may not be so angry about the way things are if you take the time to see the other person's side of things. So
Awesome.
That would be my advice.
Awesome. Thank you. So I imagine some of our listeners, some of our viewers are really intrigued by the work that you're doing, and maybe they're looking for your help. Maybe they're trying to figure out their path also, and they could use your guidance. They could use your expertise. How did they find you? How do they connect with you? What's the best way for people to reach you?
The easiest way is through my website, which is www.happydayhealth.co. You can always find me on LinkedIn, Lara Hochman, MD. But yeah, I mean, definitely reach out if you don't know what you want and you want a little coaching through that, or you are afraid that you're not going to perform well in the interviews or be able to communicate or find the right job. I'd love to help coach you through all of that good stuff, because you want to find those red flags before you sign a contract and not after you've started working there, for sure.
For sure. Well, thank you so much for being on the podcast with us today. I was so excited when you responded and said, yeah, I'm willing to do it. And I was even more excited when we started the conversation. And I don't know if anybody could tell, but I was excited through the whole conversation. So thank you so much. This was a lot of fun. It was even better than I was hoping for, better than I was expecting. So I appreciate you taking the time to join us and to share your experiences with our audience. Any last words? Oh, yeah. So you're very welcome. Any other last thoughts before we go?
Last thoughts? If you're listening to this and you're a physician, or even if you're not a physician, you're awesome, and you need to own everything that makes you awesome and figure out how to make your life as awesome as you are.
Awesome. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.